Hi, my name is Jess and I'm completing clinical this semester at the Little Clinic in Castle Rock, and today I'll be presenting on MH. MH is an 18-year-old Caucasian female and presented to our clinic with infected hands times 1 month. The patient's mother was an RN and had told her she could have a staph infection, so she wanted to get it looked at. Upon presentation, she described her bilateral hands as puffy with visible pores and reported an aching pain rated 2 out of 10. She had been having intermittent but daily symptoms present for 1 month. Exacerbating symptoms included exposure to warm water, and in addition, she played softball and had noted that wearing her softball glove exacerbated her symptoms. She denied trauma, skin abrasions, or use of new topical hand lotions or creams. No alleviating factors were noted. She denied redness, itching, and dryness, and alterations to her skin elsewhere than her hands. Her past medical history and surgical history were negative. She was not currently taking any medications. She denied food, environmental, and medication allergies. Her family history was negative. She denied any significant family medical history. For review of symptoms, she denied fatigue and fever. She denied axillary node tenderness. As noted in the HPI, she reported bilateral hand swelling, but denied any sensation of cold, numbness, or tingling to her extremities. The integument is as noted in the HPI, and in addition, she denied any color changes or abnormalities in her nail beds. For review of symptoms, the patient was alert, oriented, and cooperative. She was in no apparent distress, had an appropriate affect. Her temperature was 98.2, heart rate 76, respiration 16, blood pressure 118/72, and pain rating 2 out of 10. Her axillary lymph nodes were non-tender, non-palpable. Hands and feet were warm without edema, and she had 2+ radial and pedal pulses bilaterally. On initial presentation, her integument was negative. Her hands were pink, warm, dry, and intact bilaterally. There was no rash, lesions, or swelling noted, but the patient did believe that her symptoms could be elicited by running her hands under warm water. So we went ahead and had her do that, and after doing so, we noted a whitish diffuse scaling present on the palmar surface of her bilateral hands. There was no erythema, drainage, or swelling, and the alteration was isolated to the palmar surface of her hands. There was no alteration on the dorsum of her hands, on her feet, or elsewhere on her body. Her nails were pink without yellowing, thickening, or distortion. For differential diagnoses, we came up with dermatophytosis, contact dermatitis, psoriasis, and atopic dermatitis. So based off of the HPI and the clinical presentation of the skin alteration, and then especially the correlation between heat, moisture, and exacerbation of symptoms, we went ahead and diagnosed MH with dermatophytosis. We treated her with Lotrazone cream, applied to the affected area BID times 7 days. We instructed her to apply a thin layer of the cream, to not occlude the area with a dressing, and then we also instructed her on the potential negative effects of steroid cream use. We also did education on avoidance of reinfection, including hand hygiene, keeping her hands dry, and using absorbent powders, and then also instructed her that she should buy a new glove once her symptoms had resolved. We told the patient that if her symptoms did not improve within 1 week, she should see dermatology. So in looking at her treatment, I kind of wondered, are steroids indicated for this patient? Should steroids be used with dermatophytosis? And that brought me to the article I found. I found an article by Arabasi. He did a lit review looking at the use of steroid antifungal topicals versus antifungals alone. And what he found really is that for the most part, steroid antifungal combination creams are not indicated in the treatment of dermatophytosis. There are certain indications for them. For example, inflammatory symptomatic dermatophytosis. So people who are having a lot of pain and itching and the area is very inflamed and red, steroid cream may be indicated in those cases in the short run, but once the symptoms are treated, then they should be converted to an antifungal alone. The antifungals have been found to be as efficacious in the treatment of dermatophytosis, and they have less side effects and are less costly. So really, an antifungal alone was found to be the most appropriate treatment. So in looking at this article, really our patient did not have symptomatic inflammatory dermatophytosis, and an antifungal alone probably would have been more appropriate for her treatment. For the theorist I chose Orem. And And Orum's theory looks at an individual's ability to provide self-care and the role that the nurse plays in helping patients who have self-care deficits meet their self-care needs. So with my patient, I think Orum's concept of supportive education was appropriate. Supportive education occurs when an individual is able to meet their self-care needs but requires nursing guidance and support in decision making. So this can be applied to pretty much all patient-nurse interactions, but in the case of my patient, the patient was able to meet her self-care needs but needed some education on her diagnosis and the treatment, and needed education to prevent future reinfection. And that's it. Thanks.